Hello, good evening, friends and colleagues from the Asian Oceania country, and also good morning, friends and colleagues from the North America. So my name is Nucharin Tanya Supakol. I am one of the Asian Safe committee from Thailand. And today, this is like the second part of the lectures that we are going to talking about the optimization on the CT technology. But before we go that far, I would like to invite Dr. Jamarichia Pechera Sopon, who is the president of the AOSR, for the welcoming speech.
Hi,
Hello.
welcome everyone. It's my pleasure to welcome you all to the second episode of our 2025 webinar series by AOSR AsiaSafe team. This series is dedicated to enhancing optimization strategies in radiological practice. And today we focus on a critical topic, CT dose optimization, balancing imaging quality and patient safety. We are honored to have Dr. Brady continuing as our core speaker, and we are also delighted to welcome Dr. Wong from our own Asian Oceanian region to enrich today's discussion with regional perspective. As we explore this topic, let's reflect on how we can harmonize global expertise with local experience to advance safer and smarter imaging for all of our patients. Thank you for joining us today. Thank you, Dr. Nucharin.
Thank you so much, Dr. Jamri, for the opening speech. So as we know that this is like the second part of the lecture series, the first one we were started in 2024 that we start talking about the DRL, what, where, when, why, and how. And this is like the second part that we carry on the 2025 that we're talking about the optimization strategy. And on this series, we're gonna have a 6 lecture together starting from last month that we had some recap on the DRL. If you have not done so or watched the last live session, you can go back to the Vidocto platform or check on the AOSR YouTube channel to check on that one. And today we are going to talk about the CT dose optimization, balancing image quality with the patient safety. So let me introduce our first speaker. Let me show my screen here. So this is the first speaker that you know, Dr. Samuel Brady. He is a chief medical physicist from the Cincinnati Children's Hospital. He is an associate professor and he also received the fellows of the American Association of the, oh, you cannot see my screen, can you? Of the physicists in medicine. So he has a lot of national and international experience, including the IAEA expert, and give the lectures in the Asian country, and also part of the speaker for the first series in 2024 that we were talking about the DRL. So currently he is a vice chair of the Immediately Alliance, also the chair of the ABR Radiologist Examination Development for the Physics Qualification Core Exam, and also chair of the AAPM Annual Meeting Education Program Working Group, as well as a member and of the AAPM Ad Hoc Committee on the Artificial Intelligence Bootcamp. And I also want to introduce my the second speaker, who is also my co-moderator for today's session, Dr. Y C Wong. He is a professor and the chairman of the Department of Medical Imaging and Radiological Science at Chongqing University, Taiwan. His subspecialty is the ED radiologist and also interventional radiologist, which is involved in a lot of a patient's care and also the optimization. He has an experience as a national and international speaker for the Taiwan Radiological Congress and also the ISMRN. So he is a current chairman at the Medical Imaging and Intervention at Chongqing Memorial Hospital and also board of the director of the Taiwan Society of Interventional Radiology. So before we start with the first lectures from Dr. Batley, I want you guys to scan this QR code because this QR code is an evaluation form that we know how can we do better. What do you like or you don't like about these lectures? So when you scan this QR code form, you need to log on with your email address, and by the end of the talk, you can just give us what do you think, what is good, what is not good, what we can do better, or what you want to learn from us. And also, when you log on the Reducto platform, you're gonna see this page, right? But if you want to have some live interaction with us, sending a questions or ask any questions, so you need to join the audio to participate. So by putting your name in there and click join the audio, so by that way, during the talk within this 1 hour, you can put your questions all along the way, or your opinion or something that we can share and discuss on this platform. Yep. Okay, so let me stop my screen, and we're gonna welcome our first speaker, Dr. Samuel Brady, to the talk. Welcome, Sam.
Thank you, Tanya. It's great to be back. I appreciate the opportunity to share. I am pulling my slides up right now. Oops. There we go. All right. So, forgive me. Let me go back one screen. There we go. I appreciate the opportunity to talk to you about optimizing CT. The reality is, to optimize CT, we could spend all 6 webinar series talking just about this wonderful technology. And it was a bit of a task to decide what to talk about today. So I decided to talk about 3 foundational keys to optimizing CT. I personally believe that if we optimize these 3 ideas or tasks, that most of 80 to 90% of what you would do every day in CT will then be properly optimized for radiation output and image quality. To start off my conversation about CT, I want to take us back. I want to take us back to the very first CT scanner. In fact, the very first CT scan, the very first patient study was done all the way back in 1967. And then if you fast forward to 1971, here you see an actual live video of the first patient being scanned. Those scanners were revolutionary for the time, but they could barely scan the very top of our head, barely the cranium. We couldn't even do the full brain. After the study was complete, the study was saved to a 5.25-inch floppy disk, which was state of the art at that time. And then there were 6 Polaroid images printed for a radiologist to look at. And then fast forward about a couple years to 1976, they finally made the opening in the bore wide enough so they could actually image the body. And here you can see the first chest and abdomen scans, but they were still doing the translate rotate scan. So it took almost 4 minutes to scan just once around the patient. And you compare that to today, where our scanners, the top of the line scanners, can rotate around the patient in 0.21 seconds. And we can now scan the entire body in about a second. So the first point I want to make is that the advancement in technology in CT will bring for us the greatest dose reduction and image quality improvements. This technology tends to change about every 5 years. Now, I'm not advocating that you buy a new CT scanner every 5 years. That's not practical for most people. It's not practical for us. The reality is, though, almost all CT scanners can be upgraded, and you can always get the latest reconstruction algorithm and oftentimes new technology so that you can spin even faster. We just did that with one of our scanners, and we went from being able to spin at 0.28 seconds all the way down to 0.21 seconds, and we didn't have to change anything. It was a software upgrade. And so my first suggestion in all of this is keep your system updated, because we have gone a long way from 1970 to the early 2020s in technology. And that has very much improved the quality of what we can do in radiology. So that was just the basis. Now let's get into my talk. The first step to having the best or the most optimized dose and image quality for a patient has nothing to do with the scanner. It is meant to help us pick when to use the scanner or when to CT a patient and when not to. If it is appropriate to scan a patient, then we know the radiation dose we use for that patient is appropriate. And so setting up appropriateness guidelines allows us to know when to use the scanner and not to. And there is no better way to reduce dose to a patient than to not scan a patient if they don't need the scan. One example is here in the US, in pediatrics, the head CT protocol is the most ordered scan protocol. There is a group called Pediatric Emergency Care Applied Research Network, or PECARN for short. They came up with an appropriateness criteria for when we should image a patient that is suspected of traumatic brain injury, or TBI. And they came up with a very simple infographic shown here on the left. They subdivided it into 2 years, if you're 2 ages, less than 2 years or older than 2 years old. And they came up with the criteria that if you have altered mental state or a Glasgow coma score of less than 15 or palpable skull fracture, then it would be appropriate to do a CT scan first. But if, for example, even if the patient has had loss of consciousness or a history of vomiting, headaches, or that if one of the way they hurt their head was one of these scenarios, then actually it's probably okay just to observe the patient in the hospital, in the trauma center, and then wait. If they improve, you do not need a CT scanner. If they do not improve, then of course a CT would be warranted. And similarly, they came up with criteria for doing C-spines. This is just an example of how we can use CT scan appropriately instead of just scanning every patient that walks in the door, because not every patient needs to receive a CT scan. More generally, the organization here in America called the American College of Radiology, or ACR, they created appropriateness criteria for pretty much every scenario you can think of when it comes to imaging or ordering in a hospital. To my knowledge, it is free for everyone. I simply went to this website, clicked on it, and I was able to get in. Admittedly, I'm here in the US, so I hope it is something that you have full access to. If not, I'm almost certain any hospital can petition for access and get access to it. And so what you do is you can go to this website and you enter in some basic patient history. As an example, if you are interested to know what would be the appropriate imaging criteria for, say, a patient that presents with left lower quadrant pain, but suspected complication of diverticulitis, then yes, on the very top of the list, you can see that maybe a CT abdomen pelvis with contrast would be appropriate. And then it lists some other studies that are also appropriate, but maybe not necessary. For example, MR, or even ultrasound transabdominal. And then it will list certain procedures that would not be appropriate for this particular study indication. For example, CT abdomen pelvis with and without contrast. Additionally, this website will give you a general idea of how much radiation each of these studies would impart to the patient. For example, in this case right here, CT abdomen with contrast has 3 radiation symbols. And if you come down here and you're imaging an adult, 3 radiation symbols represents a dose between 1 to 10 millisieverts. Or if it was a pediatric patient, somewhere in the 0.3 to 3 millisievert range. So ultimately, knowing kind of what the history of the patient is can help guide us to pick the right scan examination. And CT is not always the most appropriate initially. But once CT is indicated, we should also understand what we're looking for generally. So for example, if we're doing a relatively high contrast image, for example, a shunt check in the head or an endo link in the body, you do not need a lot of radiation to make this diagnosis. Whereas if, on the other hand, you're looking for microbleeds from a trauma or a very subtle pathology in the brain or subtle pathology in the abdomen, such as maybe tumor or infection, then yes, it is warranted to use more radiation. We don't always have to use the lowest radiation possible. We just need to use the right amount of radiation for the task at hand. So that leads me to the second, probably best way to reduce dose in the patient. And this is an old technology, using tube current modulation. Tube current modulation has been around since the 1990s. And you all, I almost perfectly can assume most of you are always using this technology. Basically what this is as the scanner spins around the patient, the machine will change the radiation output, the MA, based on the size, and so thicker parts or thinner parts of the body, or it will change depending on the attenuation profile. Less attenuation, for example, in the chest through the lung field, or more attenuating through, say, the pelvis with all of the bony anatomy. And it changes and adapts that radiation so that the noise in the image is fairly constant at every slice. Now, the key to this, and this is very important from the setup perspective, is you must make sure your patient is centered in the gantry. This technology is rotational, of course, at CT, but it assumes the patient is centered in the machine. So if, for example, the patient comes in and the patient is too high, so the table is elevated too high, and we go to do the first planning scan or the scout scan, and we're doing an AP projection, if the patient's too high, they will be magnified onto the detector and their dose will be enhanced. So it'll be much higher than they would normally need. Now, the converse is true if the patient is too low in the gantry, so below the isocenter in this AP projection, then the patient would manifest as smaller than normal and the radiation dose would be lower. And one of the outputs with that would be a lot more artifacts and noise in the image. So the first key to using tube current modulation is center your patient in the gantry. Most technologies, most scanners have the technology now where they will measure the patient thickness, for example, in this lateral scout view, and they will present a line across the body. And that will show you where the center of the patient is. And then they'll present another line across the body showing you where the center of the body is with respect to the height of the table. In other words, the isocenter. And so in most technologies today, the technologist can then push a button to move the table up or down from the console room, or they have to walk in and then from the gantry, they can move the table up and down. But it's very important to use this type of technology when they have it. And if they don't have it, they should ask their vendor if this is an upgrade they can add. It's very simple, very easy, and it almost always gets your patient centered in the view. For some of the more advanced, newer technologies, these systems are coming with cameras that are either mounted on the ceiling, looking down at the table, or they're in the gantry itself, looking out or at the patient. And these cameras are also then paired with AI technology. And that those cameras and AI technology will actually move the table up and down and find the proper center of the patient. And they will move the table in and out and set the starting and end location for the scan. And that's, so if you tell the patient, I'm going to do a chest abdomen scan, it knows basically generally where to start and end. Now, this is always something that the technologists can override if they feel like the table needs to be higher or lower, or they start or stop at a different location, that's fine. But this technology is meant to help with the workflow, to help take a few less steps away from the technologist so they can focus more on the patient comfort. My one caution is these technologies are great, but they're almost always optimized for adults. And so when you're imaging pediatrics, especially little kids, toddlers, and neonates, this technology really struggles to help. And that's largely because with the curvature of the table, most of these kids sit so low into the table that the camera just can't see their actual depth. So Great technology, and it is improving all the time, but just know its limits. So the second thing you need to do once the patient is centered is you need to identify the proper level of noise acceptable for the image. As I mentioned, if you're doing, say, a shunt check, you don't really need a lot. So you can set your noise parameter relatively high. But if you're looking for infections or subtle findings, say, in the liver, then you probably need to set your noise level a little lower so you can see those low contrast objects or issues. Every vendor has their name. GE calls it the noise index. Siemens calls it the quality reference mass. However it's named, it all does the same thing. It tells the scanner how much radiation to use during tube current modulation. The second thing you need to do is set the maximum and the minimum allowed level of radiation so that the scanner will not overscan or underscan any patient. In this example here, you can see the red curve. That is the projected MA that will be used to scan this chest. And this blue horizontal line, this blue horizontal line represents the minimum MA that was set for this protocol. The problem here in this example is the system only needs maybe, say, 20 MA to get all the way through the lung field, but this minimum MA was set at, say, 75 MA, which means this area in the lung field will be overexposed. So we want to make sure the minimum MA and the maximum MA are properly set for each indication, chest imaging, abdomen, etc. You can't use a generic value for every patient body part. How can we verify this is appropriately set for our protocols? First of all, you can use your dose monitoring software. We talked a little bit about that last month in our discussion on DRLs. Most centers nowadays have a way to track the radiation, that the study level radiation for each of their CT scans. And they can create plots and whatnot using this software. If you do not have that access, you can then just go through and you can look for a collection. So maybe you look at a month's worth of chest CT scans, and you plot the maximum allowed MA for each protocol. In this case, I'm a pediatric center, so I have 5 protocols for chest exposures. And I plotted the maximum and the minimum shown here in red. And then I plotted the patient, I think this was maybe a couple days worth of patient data. And I was looking to see how many protocols had patients that were grouped on the top line or the bottom line. And if they are constantly at the top line or the bottom line, then you know your min and max MA are not appropriately set for that protocol. You want to find all of your data points in the middle somewhere. Now, the caution to this is as you do this, data on a plot is one thing. Physicists, technologists, radiologists, we all like that, right? But ultimately, we need to make sure the quality is appropriate. And this is an example where on the left, we had a patient that was receiving a protocol that was set for 70 kV, but the minimum MA was 80. And for the size, that made sense. But when the patient was scanned, you can see the liver imaging was non-diagnostic. What we did is we increased the minimum MA so that at minimum, we would make sure even the smallest patients would have a diagnostic scan. So we're not always looking for the lowest dose. We're looking for the correct dose. So make sure you look both at the data to find which protocols need to be optimized, and then look at a sampling of images on PACS to see if you need to move it up or down. When we set our noise parameters, we need to do this based on patient thickness, so their size, or weight when we are setting protocols for the chest, neck and shoulder, abdomen, pelvis, spine, or some of our MSK such as say legs, pelvis, maybe even shoulder. The reason because when you use age, if you use age to set your protocol, your noise parameters for protocol, the problem with age is, for example, the largest 17-year-old in this study is the same size as the smallest 17-year-old is the same size or thickness as the largest 3-year-old. And so if you're using age to set your noise, what's going to happen is a certain percentage of your population will be under or overexposed. We want to use weight or patient thickness when identifying which the noise value set for each protocol. The one exception to this is when we scan the head. We know the head grows logarithmically. And so after the first 5 years, most kids, 5-year-olds, have the same size head as they will for the rest of their life. And so we can generally, in pediatrics, set a couple of different protocols based on age to get the right noise in the head. The same is true about the skull density, the bone thickness. It gets denser and thicker with time, but largely after a couple of years, it's as dense as it will be for the rest of their life. So we use weight and size for the body, and we can use age, if you would like, for the head. And then from there, we have to figure out what noise parameter to set based on the speed in which we're going to image. We obviously want to go as fast as we can to help reduce repeat rates from patient motion, to reduce sedation rates for our littlest kids. And we can do that by going rotationally fast and having a fast table speed or high pitch if you're doing helical imaging. Or if you're doing true axial imaging, so the table doesn't move, then all you have to worry about is the rotational speed. In general, we want to go as fast as we can. But for some of our largest patients, if we go too fast, the machine can't push out enough MA to make the image quality diagnostic, in which case we have to slow the tube down so that it will scan the patient longer with a lower MA or with a particular MA. So understand that fast is good, but even our largest patients, sometimes we have to slow it down. So always make sure you set the right noise parameter based on their age, weight, or size, depending on what you're scanning, and then base that on the size of the patient. So if they're really big, maybe we need to slow it down a little bit. Here's an example where I went through and I measured just probably a month's worth of head scans, and I plotted it as a function of age. And I wanted to know if I could do a volumetric scan. So our CT scanner can do 16 centimeters in one rotation. And I found that pretty much every one of our patients could be scanned with a single rotation. And so we were able to convert from using helical scanning, which would then have to slide through this, to going and being able to scan every patient in 0.2 seconds, 0.21 seconds. And so we were able to figure that out. We can go really fast if we're just doing true axial for our brain scans. And so looking at which protocols you can convert to true axial, which would basically be head scans or little baby chests or little baby abdomens. Everything else, you're going to do helical, and you're going to have a relatively fast table speed or high pitch. So tube current modulation, it is fairly old technology, but there are small little nuances that keep changing with time that we have to make sure are properly optimized, because that is probably one of the best ways to reduce dose. The next one is using our KV. Lower KV is probably one of the best ways. Lowering KV is one of the best ways to reduce dose. Why is that? When we change MA, it's mathematically a linear function. When we change KV, it is a quadratic function. So what does that mean? If I change KV from going and scanning at 120 down to 80 KV because of the square nature or the quadratic nature of the equation, I can get a 56% dose reduction. If I simply change the MA and I go from 120 down to 80, because it's linear, there is no square here, I only get a 33% dose reduction. So reducing KV reduces dose faster than reducing MA. Remember, when you change MA, it changes dose and noise, which we just talked about. When you change KV, it changes the dose and the noise in the image, but it also affects the contrast, how intense the whites are or how gray the tissue is. So changing KV is great, but we have to do one other thing. We need to make sure we get the right noise in the image and then the contrast. So let's start with the first thing. Let's get the noise proper. So this is an example. Almost always you would use tube current modulation. So you would set your min and max values so that you could get the right amount of output based on noise. To demonstrate this, I'm just going to show you a fixed technique. In this case, I have a 120 kV scan of this thorax abdomen, 100 MAS. I measured noise in the mediastinum at 7.6, and it had a volume CTDI of 6.8. If I reduce my KV to 80, I keep my MA the same, you can see how the noise goes up. We already said that you'd get about a 50-something% dose reduction. That makes sense. CTDI is much lower, but the image is noisy and it's probably not diagnostic. So if I increase MA and decrease KV, you can see here, I actually matched the noise, made it a little better actually, and the dose is still lower than the very first scan. And so that's the nice thing about reducing KV. We can increase the MA to compensate for the noise, and we still get dose reduction. In our hospital, in our institution, we did this a couple of years ago where we bought a new scanner that allowed us to go from consistently imaging at 120 down to pretty much 80 kV for most patient sizes. And you can see here the commensurate reduction in noise in CTDI. And what we found was that over 1 year, we saw a shift in our population dose by about 50%, going from routinely imaging at 120 or high KV to lower KV. In general, this is just a general breakdown of how we do it. Everyone does it slightly different. But for our smaller patients, so patients that would measure less than 30 centimeters, if you take their anterior, posterior, and lateral dimensions and add them together, which is typically less than a 15-kilo patient, we image them at 70 kV. For the vast majority of our patients, we image them at 80 kV, so basically up to 70, 80 kilograms. And then for some of our larger patients, we'll image them up to 100. Our very obese patients, we oftentimes will image them at 120. In the head, we will generally scan at less than 5 years because the skull is not as dense or thick. We can scan at 100 kV to get better gray-white differentiation. But then over 5 years, we always do 120 to penetrate the skull. It's important to know that when you're imaging at low KV, you need a scanner, a system that has a tube that can reach relatively high MA. So you need to talk to the vendor to make sure your system can go high MA so that you can compensate for that noise in your low KV imaging. I mentioned that being able to, when you change KV, you change the inherent contrast or the intensity of the white in the image. And that's a good thing because, for example, in pediatrics, we can actually reduce the amount of IV contrast we inject into our patients. In this example, if you're injecting, there's different KVs, that's what each of these lines are. And this is different iodine concentrations on the x-axis. And here on the y-axis is the contrast to noise ratio divided by the dose. And so if you want to keep the same contrast, the same intensity of the image, and the same dose, you can see how you can actually reduce the amount of concentrated iodine concentration if you go from 140, 120, 100, et cetera. As you go lower in KV, you can slide left along this line. And so for kids, for pediatrics, we generally can use less and less iodine concentration with lower KV. The next type of thing we can do when you reduce KV is also changing the modulation or the exposure across the anterior portion of the body. This is something called organ dose modulation. So we already talked about how MA changes as it rotates around, but now we can tell it to also reduce the MA along the anterior sweep of the body. And this has been shown to reduce the overall dose, radiation dose to these anterior structures, such as the eye, thyroid, or breast tissue, by 25 to 30%. It's an additional reduction to these sensitive tissues. And we have found that when you sometimes need to image pregnant patients, This is a great way to help reduce the fetal dose when you use organ dose modulation. We find in some studies we've done, this was a cadaver study we did, yes, the noise does change a lot, slightly, is a little noisier anterior, but for most part, what the patient or the radiologist needed to see, that did not change. The confidence of their diagnostic task did not change. If you're imaging for the orbits, then maybe you wouldn't want to use this. But if you're imaging deeper into the body, that's not a big deal. The one caveat to this is one vendor uses a technology that when it sweeps across the anterior, it reduces the dose, but when it sweeps across the posterior side of the body, it raises the dose. It keeps the integral dose to the body the same. And so that's fine. It still reduces your anterior organs, which is the more sensitive ones in this case, but it's not really something I would recommend using for fetal imaging, because you have the potential to increase the dose to the fetus from the backside. And then when we're setting the, finally, when we're setting the technology, or setting the proper noise parameters and KV, make sure you always acquire every image using the thinnest slice. The thinnest slice is going to be usually 0.625 for a GE scanner or 0.5 for everyone else. And this will allow you to have the best looking reformats, sagittal and coronal. But when you acquire the images using the thinnest slice, you set your noise parameter based on the thickest image that you will reconstruct and give to the radiologist. So sometimes we'll send them 5 millimeters or 2.5 millimeter thick images. Well, we will set the noise parameters for these thicker images, but so they can see what they need to see, but then they don't have to worry about having a too high a dose for the patient. So very quickly to review, set your appropriateness criteria, image only when necessary, set your tube current modulation so that the noise parameters are set based on patient size or weight or age if it's the head, and use organ dose modulation if you have that technology. If not, you can always ask for the upgrade. This is a great way to reduce dose to the critical organs, to several critical organs. And then as much as possible, always use lower KV imaging, especially for little kids. All right, a couple of things we can talk about for reconstruction algorithms is there are three major types. There's filter back projection, there's iterative reconstruction, and deep learning technology. Iterative reconstruction and deep learning, they reduce the noise in the image. That is their primary task. And so we can go from the left image to the bottom right image. Now, iterative reconstruction imaging has always done really good at reducing noise, but if you turn up the reconstruction algorithm too high, so it reduces too much noise, it tends to actually make the image a little more blurry. It makes it a little less appealing to the eye. Deep learning reconstruction has largely overcome this limitation and allowed us to really remove most of the noise without changing the way the image looks. The question is, can we use deep learning reconstruction to further reduce the dose to the patient? Iterative reconstruction has generally been limited to a dose reduction of about 20 to 30%. If you have deep learning reconstruction and you ask for this upgrade, if you don't, we have found that you can largely reduce your dose even again down to 70%. And that's because you can go all the way down about 70% before you start to see a change in the pixelation or the noise content in the image. And now let me give you kind of a clinical example. Here I took iterative reconstruction image and I subtracted it from a filter back projected image. Everything you see in this image is data that has been removed from the iterative reconstruction image. So you can see all this detail in the lung parenchyma, all of the vasculature and whatnot is gone. And so we don't want that. That softens and makes the image not look appropriate. But with deep learning, you can see that it really doesn't subtract much from the image. It mostly just takes the noise out, which is a good thing. So upgrading to these deep learning algorithms has done a great job at making the images look less noisy, but also allowing us to reduce the dose. The caveat thing I warn you about is using iterative reconstruction or deep learning does not change the contrast of the image. So it removes noise only. If you want to be able to visualize a low contrast object, you can only reduce the noise or the dose so much before you just lose the ability to visualize these little low contrast objects. In this case, obviously, filter back projection is kind of hard to see. Deep learning makes it a little better, but the inherent contrast to noise ratio does not change. So just know that you can't keep lowering the dose forever. There comes a point where even the technology itself is limited. It's really good at removing noise, and it's really good at sharpening the image, but it's not going to be able to increase the contrast. A new technology that has been come out is using deep learning reconstruction with higher matrix sizes, using 1024 instead of 512 reconstructed matrices. And that gives you the ability to have in-plane resolution that is 0.25 millimeters instead of standard half millimeter. Now, if you looked at the image, and I know this is so small, so you probably can't tell, but the detail is stronger, the edges are sharper, and there's less noise. The difference of being able to diagnostically assess the scan, probably no different. We're still looking to see how this technology will impact diagnostic confidence, but in general, it's making the images look better. And so it's a technology worth upgrading for if you have that option. So quick review, deep learning reconstruction allows us to reduce dose by upwards of 70%. It does not change contrast. So if you have a very low contrast task, you need to be careful how low you reduce the dose. And then using this new technology with 1024 matrices instead of 512 will allow you to have better quality sharpness in the image. And then just in the last couple of slides, I wanted to talk about new CT technology. So photon counting CT is probably the newest technology on the market. And what does it provide for us? And so that really gives us three major things. So our current system, when radiation comes in and the X-rays convert to light, they turn to light and then they are collected down here at the detector. Part of that, however, is the reason we can collect at the detector is because we have these cuts in the detector. And then we put this reflective material in there so the light gets filtered down to the bottom. The more cuts you make in the actual detector material means less area to absorb X-rays, so they become less sensitive. Therefore, our current scanners require higher radiation dose compared to a photon counting where the X-ray comes in and converts to electrons instead of light. And those can then, you can see here, they're not spread out. They go straight down to the pixelated detector and they're counted. So the first thing photon counting detectors can do, because we don't have to cut their detector elements up, is they allow for much better, smaller spatial resolution. The next thing they're able to do is because each one of those electrons comes in with a unique energy, we're able to map or count each photon and look at the energy spectrum of those electrons. And we know that there's a certain level of energy that is only just noise, and we don't want that. And so in our current system, we can only take what we receive in that detector element, all of the all of the X-rays converted to light, all of that signal plus the noise is integrated into one signal. But in the photon counting detector, we can, because we're looking at the different energy signatures of each electron, we can identify what is noise and remove it. And then we can look at all of the individual electrons and their noise profiles, energy profiles. So because of this, every image is spectral by nature. It's not just dual energy. We can do multiple bins. We can do 3, 4, 5, 6 bins worth of energy. But because we are reconstructing without that noise profile, we do not have, the images are inherently less noisy. And then finally, the last area that is enhancement with photon counting is the fact that when we spin around, we are only able to image about 2,000 times per rotation. And so what that does is it causes the image in the periphery to be a little more blurry because the sampling rate at the periphery is different than at the center. And so you can see that in this case, the shoulder, which is more central to the image versus the elbow, which is more periphery, you see more detail in the shoulder versus the elbow. With photon counting, as it spins around, we're able to acquire more like 6,000 projections per rotation. And because of that, there is a lot less, there is hardly any blur at the periphery compared to the center. And so resolution is better inherently, but it's also better throughout the entire image, center to periphery. So this is just one example in the patient here where we can actually get better spatial resolution because we're imaging with smaller matrices or pixels, and the noise can be lower because the system is inherently less noisy. So I want to thank you for this, and if you have any questions, we can either take them now or at the end of Dr. Wong's talk.
Thank you so much, Sam, for the excellent lectures as always and for the clarifications. So I would like to have like the question and answer at the end. We're gonna have time for Dr. Wong to give a talk that related to the clinical practice as a radiologist. What can we do in terms of the optimization? Yep, welcome, Dr. Wong.
Thank you very much. Let's see whether I can share my PowerPoint or not. Am I sharing correctly? Correct.
Yes,
Yes.
and you need to
Okay.
go to, yep, good now.
Okay. Can you hear my voice? I
Yes,
hope so, because I have done a little modification of my earphones here. And then I'm going to talk on the CT dose optimization, balancing image quality and patient safety. Ionizing radiation has become more and more about 18% of the ionizing radiations comes from the medical examinations, and 60% out of the 18% of ionization radiation exposure of the CT. So CT is the largest single contributor of the ionizing radiation in medical examinations, although it only accounts for 15% of all diagnostic imaging exam, but it causes 70%, around 70% of total medical radiation dose. That is why Evelyn Ho has given me this topic to reduce CT dose, because CT is the main contributor, as I said just now, and the dose is cumulative. It is not reset every year. And the cancer risk is stochastic. So it depends on the dose and not depends on the more the dose, the easier for a patient to become cancer risk, but there is no threshold for the cancer risk. What I said is that stochastic is this. So to reduce CT dose is something like sitting on the scale, balancing scale. In one side of the scale is the CT dose. The other side is the imaging quality. That means, sorry, I don't think. Can you see my slide now? Okay, sorry. Can't see my slide. Where's my slide? Sorry. Wait for a minute. I can
we can still see your
simply.
slides.
I can't see my slide now. Where's my slide now? Sorry. Can you see my slide?
Yes, I can.
Maybe I can re sharing again. Okay. So reducing CT dose is like sitting on the balance scale, and then one side is the CT dose, the other side is the imaging noise. So look at the noise level here. As Dr. Sam has told us, that noise level, the bigger the noise level, the bigger is the noise that we have to focus on to delete the noise if we can have a diagnostic image or not. So it is good to have as low as reasonably achievable CT dose, and then maintain diagnostic image quality and avoid repeats. Repeat is not our main objective in this setting. So we have Atomic Energy Council in my country, and it was founded in 1955. It is under the executive yuan, this of cabinet level. And then it regulate nuclear safety. But the most important task of the council is this that I highlighted: supervises the safe use of radiation medicine, and then issues diagnostic reference levels for imaging procedures, and then monitors occupational exposure among workers. Recently, I have talked to the Atomic Energy Council whether the students are workers or not. Their answer is quite not happy for me. So this is the diagnostic reference levels for average 70 kilogram adults. So look at the head non-contrast CT is about 60 CTDI volume. We can't measure the patient with DPL because the length of the patient is not constant. So we can use CTDI 60, and then neck single pass is 25, chest non-contrast 10, abdominal pelvis non-contrast 15, and contrasted chest, abdomen pelvis together, it is 12. So each hospital has also its own hospital radiation protection committee. Like our hospital, we have one hospital radiation protection committee. It is under the superintendent office. Like the chairperson, it is chaired by the vice superintendent, which is vice president of our hospital, and then the chair of each department can be rotating to become the deputy chair of that committee. Like me, I've been doing the second deputy chair for a couple of years, and then radiation protection officer. We have quite a number of them. Protection officer, but it depends on the committee of. It depends on the size of the hospital. If the size of the hospital is not that large, then the radiation protection officer will be less in amount. Then we have medical staff from each department of the radiology. For example, we have diagnostic radiology, we have nuclear medicine, we have radiation oncology, and then other medical staff as well. We have technologists from the three departments. We have occupational safety representative, we have administrative staff together. We form the Radiation Protection Committee. Radiation Protection Committee has quite a number of roles to play, but the important roles that I listed on this slide are the radiation safety policy planning, because every planning of the hospital has to come through the Radiation Protection Committee, and the Protection Committee will tell the superintendent what to do. And the oversight of staff exposure, we have to see, the RPC have to take care of the staff exposure. That means we have to look at the TLD, that is the dosimetry batch of the patient of the workers every day, every month, on a monthly basis. We have to ensure protection device safety. For example, the apron, the lead gloves. We have to make sure that they are not defective. They're effective. They're not defective. So DRL and those CT dose compliance checks. We have to make sure that every every scanner, every CT scanner, for example, every medical examination techniques have to follow the DRL CT dose compliance checks. And then we have to make sure that the hospital has to have at least 3 hours per year for the training education of the staff. So I have been advocating the implementation of a radiation protection passport on the hospital, but I failed totally because of the reasons that I will give you later on. RadioSafe is a password that I think it is useful because we can have a glance at the cumulative dose from the patient in the hospital, whether the patient has overshoot the maximum background of the yearly cumulative dose or not. we can also have the pie chart, color-coded pie chart, for example, here, and it denotes the background. As for example, the background is a blue color, and then the CT scan is green, in green color. We can code that the green color, whether the green color becomes bigger or smaller, depends on uh, the exams that the patient has taken per year. So whole body CT is amazing in the trauma setting, emergency trauma setting, because it provides not only the functional, the anatomic information, but it also provides functional information as well. That is why people are using CT more liberally, and then CT, whole body CT can be performed to screen trauma patients in emergency setting. So let me talk about the advantages for whole body CT and disadvantages for whole body CT first. Advantages for whole body CT is rapid and accurate because CT can be done in a couple of seconds only, less than 1 minute. So all the data can come out with rapid and accurate diagnosis, especially if the patient has multiple areas of concern. And then also the patient has some altered mental status or unreliable physical exam because of intoxication, of intubation or unconsciousness. So this is quite common in traumatic patients. So we have to use the whole body CT for screening. And then it is efficient in triage also because trauma surgeons know what to do after they have looked at the CT images. They know what to do. So triage is more important than outcome because outcome, I don't think whole body CT can change the outcome anymore because of the mortality cases are always negative on the trauma CT, on the whole body CT, but it can cause efficient triage. And then disadvantages of whole body CT is of course the radiation risk because of the whole body CT. The radiation dose should increase quite a bit, and then overdiagnosis because of the false positivity of the CT. Even if you use artificial intelligence, it is not easy for us to not overdiagnose the cases. For example, if we can see lung cancer, what to do? If we can see lung cancer, we can have relevant findings for trauma CT, but we have findings of lung cancer, so we have to do intervention or further workup for the patient, and then this is unnecessary. I think so. So it can cause increased workload for radiologists and technologists because of this one of false positivity, and then it can increase the workload of radiologists and technologists, and then it may delay other patients who needs his exam in a limited source hospital. So radiation protection issues of the CT, whole body CT. I will take this for example, and we have done the CT of the non-contrast CT from the head to the C-spine, non-contrast, and then chest, abdomen, pelvis with single pass contrast enhanced only CT. Then these are the parameters that we use. For example, just now, the Dr. Sam has told us about the thickness and about the modulations and so on, iterative algorithm, all those things. What we do is the follow ALARA principle as soon as possible, as low as reasonably achievable principle. Then we have to think of alternative imaging if necessary. If the patient is radiosensitive, what about if radiosensitive, and what about if the patient is stable? Then we can choose other modality for the patients. So if the patient is unstable or relatively unstable, then we have to use CT because CT is quite accurate and rapid tool to use. So we have to think of alternative imaging if necessary. And then we have to streamline the patients into protocol optimization because of the size of the patient. For example, 70 kilograms, we call it the average average weight in Taiwan. And then people who are weighing more than 90 kilograms, we say that the patient is big, and the patient is 50 kilograms or less, we say that the patient is small size. So in different size, we can have a different automated exposure control. So we can set the automation exposure control next after we know the sizes of the patients, and then we have to think of the noise levels. Like Dr. Sam has told just now, noise levels is quite important because if we can produce a CT image with a poorer image, what can we do? Well, what we can do is to call back the patient for repeat scan. This is what I said before, that this is quite noise, not useful anymore because of the patient. We have to use noise level to determine whether we have to uh, think of repeating scan or not. So we have to use iterative reconstruction techniques. For example, if I use Canon, I use either 3D for iterative reconstruction techniques. If the patient, if the vendors are different, then the name of the iterative reconstructions can be different. So we have to leave the arm positioning above the shoulder for less less radiation exposure if possible. If not, if the patient is conscious, then we can lift the arms downwards, then we scan the head and neck, and then when we scan the whole body torso, then we can lift the arms upward, elevate the arms upward, then we can see whether the patient has the ability to cooperate with us or not. So the dose reduction strategies that we employ right now is the RPC, that is the the Hospital Radiation Protection Committee. This is also their work to do. We have to educate our radiologists to know how to reduce the dose. We have to educate our technologists, because technologists, they are the first line, the workers who face the patients directly. If the technologists don't know how to use the machine, even if you have bought the machines, then it is useless. So we have to know how to do the procedures quite right, fully. And then we have to educate the new employees. New employees, when they come to the hospital, we have to educate them every 3 hours, at least 3 hours per year. Then we have to have continuing education to referring physician as well, because they are the ones who order the exams. Because if they do not know the dose, they think of CT is quite safe for them, because just patients just have to go for scanning, and then the patient, we have no password right now, so we don't know exactly how many radiation dose that the patient has been undergoing. So it is not quite useless if we do not know the education from the referring physician has to know us well, they have to know the machine well also. Administrative measures, we have to know the administrations, for example, the password book that I mentioned just now, the protection has password just now. Overdiagnosis, false positive. So what are the false positive that we can see is here? For example, gallbladder, it's 15.4%, 15.4%. Atherosclerosis, 15.4%. They are false negative, false positive, sorry. They are not relevant to trauma setting, trauma CT, whole body CT, but we can see the findings quite clearly. So what to do next? Do we have to follow them, or do we have to further look out for them? So it depends on the hospital principle, whether we have to follow the patient or whether we just neglect the patient and let the patient go home. 8.2% of the patient has false positive CT. So underdiagnosis, what about underdiagnosis? For example, this is initially it is a diaphragm rupture, but we missed the findings. And then 5 months later, wow, look at the bowel herniation through the through the diaphragm to the hemithorax. It is quite obvious right now, but it is 5 months later. So I don't know whether your hospital has a patient sue, litigation issues for false negativity or false positivity. False, false negative, when you say that the patient is normal, the scan is normal, but later on, when somebody has found that the CT is abnormal, then this patient can come and sue us. It is more likely that the patient will come back and sue us. Well, what if the patient has a tumor, then we tell them tumor, then he has to undergo a further workup. And the further workup after that, the further workup tell the patient that the patient is safe from cancer, then the patient is happy, too happy to sue us. Too happy to sue us, then we have not have litigation issue anymore. So are you satisfied with these findings or not? I think false negativity is not good for the patient. False positivity is also not good for the patient. So the patient should have come after us also. So the whole body CT will increase the workload for the radiologists and technicians because we are burned out easily, not only in Taiwan, but in other countries as well. We are consumed with the whole body CT. If we have one whole body CT in the morning sessions, then it can take us three, four patients away. So it is quite difficult for us to tackle the problems of whole body CT, even though it can be taken, it can be done in a short period of time, but the reading time is prolonged for us. So even if we employ artificial intelligence to read images, it is causes a lot of false positivities. So it is not good for artificial intelligence as well. No extra reimbursement for the mobile CT or AI in our hospital, in our country. There's no extra reimbursement. That means if the patient has to undergo 4 parts examination, then it is the same amount of money as one part of the reimbursement from the hospital, from the bureau is still the same. There is no extra charge. Too many false positivities that I've said just now. So CT scans account for the majority of radiation hazard that we have all known that 60% of the about 60% of the medical exams are from the CT exam. So the CT has been the majority of radiation hazard nowadays. Ovary CT is the best screening stabilized for stabilized trauma patients, but it is not good for us because ovary CT that I've told you that the advantages and disadvantages. The advantages is much more than the disadvantages. So whether it is appropriate to use it or not, it depends on the hospital principle. We can apply a Laura principle to reduce the dose. We can maintain image quality and postpone other issues at the same time. At the current time, we have to postpone other issues like the reimbursement issue. We have to postpone the issues to the later stage. We have to know whether we have to maintain diagnostic quality and apply Laura principle first. That's all, I think. Okay.
Thank you so
Sorry.
much, Dr. Wong, that give us the
Thank you.
perspective of radiologists and how can we do as at the big level to improve the quality for your community and for your hospital. That's great.
Yeah.
So I think we have maybe a 20 minutes for the question and answer session. But before we go that far, I would like to ask the audience, if you log on to the VDoctor, you need to log on to the chat. You can use your fake name, like a dot 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 555 or whatsoever. So by that way, you can see the link on the evaluation and you can put the questions and answer on that one. Or you can scan the QR code that I'm gonna share it here if you want to give us on the feedback on the lectures and things. So we have several questions. I can start with the first question from Dr. Jamri. You want to answer by yourself, Dr. Jamri, or do you want me to read it for you? Okay. You are muted.
Sorry. Thank you. Thank you very much, both of the lecturers who give us very practical way of working on the patients. To my understanding, all of the new technologies in dose optimization, for example, iterative reconstruction, deep learning reconstruction, or AI-based, they all use they need a bit more powerful computer and also a bit of a better hardware, which in terms of energy consumption and sustainability, is that against what we try to looking for in terms of reduce all the energy consumption? How far do you think, how far can we go for try to optimize everything, use low dose, but then a lot of computer power try to make the picture good enough for our radiologists to interpret, or even for the AI to interpret?
Yeah. So in CT, most scan models will have iterative reconstruction as an option. So Dr. Wong talked about AIDER 3D on Canon or ACER for GE. Those do not require too much more power than our old filter back projection. So in that case, if you buy a pretty mid-level CT scanner today, you would be able to do most of what both Dr. Wong and I talked about with iterative reconstruction using tube current modulation, and it's not going to be too powerful that would be limiting to anyone. As long as they have standard capacity at a hospital, they would be able to do really good dose reduction without too much power consumption. AI, yes, that requires really big computers. It takes a lot longer to reconstruct those images. Photon counting, even more. And so those will probably be found in academic centers only for a while. But as technology gets better and as the manufacturers find ways to do things faster and lower energy, I think we'll see even community level hospitals adopting AI routinely.
Thank you. Dr. Wong, do you have any comment on computer energy using? Because when I heard about training kind of ChatGPT-4 that spend only training the models that spend kind of get the power for over 1,000 family consumption for a year, something like that, and it's kind of scare me as well. But AI helped a lot during. I mean, every day, everyone now using the AI in a way. But how do you think about
No, I'm sorry.
our radiologists?
I don't think we have used AI for dose reduction, but as Dr. Sam has told us just now that AI can be used for dose reduction, but I do not use dose reduction AI models. I use iterative algorithm. Iterative algorithms come by the machine at all, actually. So it is easy for us to play the IR than the AI in dose reduction, but I play AI in chest, for example, for detecting new nodules, but that are not good. I don't think so.
Yeah.
I don't think so.
May I add one more comment? A lot of what Dr. Wong is also talking about, these AI models for interpretation and diagnostic tasks, a lot of those are now in the cloud. And so you may not need the power consumption locally. You just need to be able to transmit up, and then it's going to be somewhere else, and they will do the number crunching, and then the data will come back down at your local level, and then in your PACS or your reading room, you would be able to observe the results.
Thank you. Yeah. So to follow up the previous question, this is a question from Dr. Evelyn Ho. So for both of you, so the appropriate indication is the most important to avoid the inappropriate and unnecessary examination. So how do they ensure the referring physician buy into this idea? So for Dr. Wong, how does the Taiwan ensure referring physician and even radiologist are updated regularly and not order unnecessary, especially in the defensive medicine that we don't want to get through. And you also mentioned the whole body CT, which is like a easily for them to check, to order, easily for us to get our scan, but it's very painful when we need to read those studies. It's so painful, right? And for Dr. Bradley, so for the pediatrician and pediatric radiology, everyone is far more recognized and responsible in the way that they are ordered and also conduct the examination. But many hospital don't have like the dedicated scanner for the pediatric patient. So how can we fix it?
Yeah.
Dr. Wong, you
Let
can
me
go
answer
first.
first, okay?
Yes, please.
According to Dr. Ho, the question was whether our hospital doctors can follow the order or not. But it becomes quite difficult for us because of defensive medicine, as you say just now. Defensive medicine means that the people who are afraid of being sued, they are quite use cities quite liberally, and then the workload becomes a burden for us, for radiologists, not for the doctors who are requesting the examinations. That is why it is not easy for us uh, to to talk them down, but it is easy for us to have education per year. That is, our PC has to work, has to come out and work for the education work education, and then they have to order the exam. The exam will turn out the page that tell us the patient has the background radiation dose, how much the patient has received, how much the patient has undergone the examination in the past whole year, the past 3 years or 5 years, but we have not produced the past work anyway. Password is still important for us to be implemented, but it is not yet successfully implemented. That's what I think. That's what I said just now.
Yeah. Yeah. And to add to Dr. Wong, and then I'll answer my question. Education is absolutely the most important. And we, here in the US, we obviously want to educate our peers, but we also actually work at the medical student level. They're the ones that will change most of what we do in the future. And so we teach them what radiation is, what appropriate scans are, and help them as they then go off and become pediatricians or internalists. And they're the ones that are on the front line and they see our patients. So I absolutely agree with everything Dr. Wong said. We have to work with our peers and the future trainees. And then the question that was with respect to pediatrics, it's near and dear to my heart. The problem is, as was pointed out by Dr. Ho, almost all pediatric imaging is done on scanners that almost routinely always image adults. And so we have to be very careful when we set up protocols and we teach our technologists how to access protocols based on pediatric sizes. And so it's not appropriate to set one or two protocols, large, small, because those are good for adults. You need to have very specific protocols also built for kids. And we would recommend at least 3 pediatric level protocols. So your really small neonate, your toddler, and then maybe some like an adolescent to teenager level. After you get to being 16 years and older, you're largely just an adult. And so we could probably be okay imaging with a small adult protocol. But internally, even though teenagers can look big, internally they are different. They don't have as much interstitial fat. they look different. So we have to take the time to set up protocols for kids. Tube current modulation is amazing. So really what you need to do is set up multiple protocols. And as Dr. Wong indicated, make sure your noise indexes or levels are set right. And you can do this on even the simplest CT scanner. We don't have to worry about the big expensive scanners. If you focus on appropriateness criteria, setting the protocols for kids, pediatrics, and adults, and then making sure your tube current modulation works, you are 90% there at making sure the dose is right for the image quality needed for our radiologists.
Yeah, sure. Thank you so much. I would like to confirm that the ACR appropriateness criteria is free. So no
Okay.
matter what location you are, Thailand, Asian, America, you can download. They have like the channel for you to download, like a free download or something. So it's free, and I think this is a good resource. And I mean, based on my experience, I would say that like the first step for the optimization is we need to stop unnecessary radiation. And I mean, like we don't need to scan. And I would say that like my technologists, they are pretty good on that part. I'm not sure, like, is it the same thing or not? But like, when the ordering physician put the order, they are the one who see the order, and they are the one like, oh, it's like it's the indication, and the order seem weird. Why they need like a without and with contrast together, and then they are going to be the one who like talk to us as a radiologist, like, what do you think? I don't think that we need the with contrast, or I don't think that we need to scan patient 2 times. What do you think? And they are more like the gatekeeper for us to like the screening on the indication things. I'm not sure like that you guys have the same experience or not. Yeah.
Yeah, I agree. Go ahead, Dr. Wong.
Okay, good. Sorry, Dr. Sam. I thought that the Americans people are more likely to do the exam than the British people, and then the British they follow the orders by their superiors, and then I was told that it's true. I don't know whether it's true or not. I left Dr. Brady to talk on the issue first. Dr. Brady, please.
Yeah, thank you. I agree very much with what Tanya mentioned. We are the gatekeepers in radiology. Everyone will make the request for imaging. We need to own those requests. Technologists are amazing. We need to empower them to not just say yes, like Dr.
No.
Wong is saying, but give them the ability to feel comfortable talking to radiologists and saying, I don't know if this is correct. Because they have the ability to, because they image patients all the time. They see our patients physically. So they know the limitations of the machines and they know really what can be optimized. And so we can then, as radiologists, go back to our colleagues and say, we don't feel like this is necessary. We suggest doing this or this, and this is why. And so that feedback loop helps them in the future realize, oh, well, then maybe we don't have to do head to toe imaging on every patient that comes into our emergency room.
Yeah, yeah. So this is more like the follow-up of the previous question that we are talking about the protocol, we are talking about the technique. So this is a questions to Dr. Bradley. The pediatric CT, we have like the body part and CT head, right? So you mentioned that you choose the KVCT protocol based on the patient's weight for the body, correct? Right? And
Yes.
what is about the MA and about like the technique on the machine moderation technique that do you use? And the question is about like the DRL guideline for the pediatric CT, how we can use it for those
Yeah.
guidelines. Yeah. And I have another question, but you can answer this one
Yeah.
first.
Yes. Setting the proper MA or the maximum and minimum, that range, it depends on the noise. And so if you have a range that you've set, let's say 150 to 800 MA. And so that's what you're going to image, let's say a teenager, kind of that size patient, a 70 kilo patient. Then what you do is you can set your noise index and you can look to see if you're going too high, the MA is consistently too high, or if it's consistently too low, and then you know you've set your noise, that noise parameter incorrectly. It's hard to just say, oh, every 70 kilo patient gets a noise index of 10, and then you set your maximum at, say, 500, because that really also depends on what your radiologist prefers. But the DRLs will give you a high level. And so if you set up a protocol and that protocol CTDI, let's say it says 15 milligray for an abdomen scan, and you look at your DRL, and that DRL is, let's say it's also 15, then for that patient population, you know you're at or around 75% of all your peers. So that's okay. If you then start scanning around that level, and then you realize, oh, this is really good image quality, we don't need this much, then you can start to bring it down. And so setting your CTDI to be no higher than the DRL is a good place to start for all your protocols. And then you can kind of work your way down if the radiologist is okay.
Yeah. So which mean like normally on the end of the scan on the CT, we're gonna have the dose exposure page. So which mean do you recommend that we should check on that page every time and at least have like the CT DRL number? I believe that we have the paper on the pediatric dose on the DRL on recently published on the radiographic or radiology. Right?
Yeah. So individual patients, those numbers can bounce a little bit. And so if one patient walks in the door and they're below the DRL, that's good. If the next one comes and they're a little higher, that's okay. Don't make a change yet. You need to start collecting more and more data. And so you look at those dose report sheets, or you use your dose monitoring software if you have it, and look for a week, 2 weeks, a month, a couple of months. And then if you notice that consistently they're higher, then you need to make an adjustment. If you're consistently lower and there's only 1 or 2 outliers above, you're okay. You're okay.
And we can find those reference level at least for the US on the radiographic, right? If I remember correctly.
So for X-ray in the US, they do not have any published ones yet. In Europe, they have a lot. Europe is a really good place, and there are a few in Asia too. Like I think Korea and Japan have some.
And
For CT, every country you can pretty much find. Every region will have some really good DRLs.
Dr. Wong, you have anything to add on?
Yeah. What about the passbook? The passbook. Do you have the passbook? As I said just now, that if the protection passbook is available, then it will be good for us to monitor the patients. I don't know whether Thailand or US you have the passbook or not. We've got my question correctly. Sorry, Brady.
Yeah. When you're referring to the passcode, the pass level, or I don't know.
Passbook.
I don't think you need. Yeah, I don't know if you need a pass.
The passbook that you have mentioned during your lecture, right, Dr. Wong?
Yeah.
The passbook that do create the radiation. I don't think we have that kind yet, but it's kind of interesting to maybe develop.
Yeah, and we don't really have that in the US either.
Oh, I see.
Logbook.
But according to my hospital management, they said that the requesting physicians, they are afraid of being sued because of the patient may come after them because of the dose they have received so much.
Yeah.
I don't know whether it is true or not.
We don't really. Yeah, Europe has looked at this, but in the US we don't do this. Because cumulative radiation dose is something different than individual protocol doses. And so if you get a CT scan twice a year, that risk is different than if you get a CT scan twice a day. And so we personally here in the US, we monitor that differently. And that's why we don't necessarily collect that and share it with the patients. Now, I know in Europe they do it slightly differently. And obviously they do it differently where you're at too. So I caution using cumulative radiation dose because you have to explain in context how you've received it, like what time frame you've received the dose.
Okay, yeah. So the next question is about the contrast dose reduction. Do you have any guideline or protocol we can refer to? So I'm not sure that you can answer this one or not, but maybe you can, Sam. How much contrast volume that do you use? Like a one less than 1.5 or 2 cc per kilogram? I can
Oh,
speak on my
yeah.
experience. I can speak on my experience, but I can
Oh,
let you go first.
no, good. No, go ahead. You go ahead. That's good.
So I think right now with the new technology in the past, this is more like a ballpark number that we say that we can give the contrast volume to the patient, maybe like a 2 cc per kilogram with the max of maybe like a 3 or 4 cc per kilogram. But with the new technology that we have right now, we can lower the contrast volume because we have like a dual energy or spectral CT that we can adjust the volume and make the images that close to the KH of iodine. So which means right now, the volume can go like a lower than I think right now we do like a 1.3 to 1.5, depends on the age, heart rate, and also like the weight, the body size of the patient. That what I use right now in my current practice. Is it the same for you or not?
Yes, you can definitely do that. You're a little more limited if you don't have dual energy, but you can
Mhm,
still go low kV. So if you're doing, say, 70 or 80 kV, and you used to do 120 kV all the
mhm,
time, you can reduce it, maybe not all the way down to 1.3 cc's per kilogram. Maybe you're still limited to 1.5. But we are just like Tanya mentioned, we've been able to slowly reduce it, and we definitely are able to do this for the littlest of kids. For
mhm,
adults, it's harder just because they are larger and we have to use higher kV. So
mhm,
for the centers that can use dual energy, that is an absolute great option. Or even the photon counting spectral imaging, that's even more. But for everyone else, if you just want to slowly reduce it, as long as you can go down in kV, you have to be able to go down in kV. If you can't
mhm,
image down at 80 kV, then I wouldn't make changes yet.
mhm.
It is good for vascular enhancement, but it's not good for liver enhancement, kidney enhancement, for example, spleen enhancement. Because of the organ perfusion, we have to
Yeah,
give them the full dose. If not 1.5, I think it's enough. 1.3 is too low for me. 1.5 is okay. But for vascular dose, then it is easier for us to reduce the dose. I think
yes,
so.
Yeah. Thank
that's
you
a
so much.
great point.
Yes. So then can I go back to you, Dr. Wong? You mentioned about the whole body CT. So my question, and this is something that I always have an issue, is when you scan the whole body CT, are you doing more like a head and cervical spine as one part, chest and the abdomen as one part, or you scan everything at the same time, and you are doing like a head in or the lower part in? Because this is the thing that I having an issue with the image quality. What is your
No,
recommendation
I
on
don't
the
think so.
practice?
I don't think so because for the head and neck CT, we do it on the non-contrast basis. So
Uh-huh.
non-contrast it does not change much on the noise as well as the image quality. I don't think so. If you give them contrast, then it may say the shoulder point is quite heavy with contrast. Then it will be difficult for us to see the contrast
Mhm,
ratio. But to the brain, because of the non-contrast issue, I don't think so. I don't think it is quite different from head to toe or from toe to head. I don't think there is any difference. I do not know whether Dr. Sam, you have the same question, you said the same answer as I
because
do.
I know that hands up and hands down with the artifact things also.
Yeah.
Yeah. And sometimes it's not only the CT cervical spine, it's also CTA neck. Okay, hands up or hands down.
Yeah,
Hands up.
that is hard. Yeah, because if you're going to do hands up, uh, so if you're doing whole body, you really have to do two scout scans. So hands down, scout scan the body, do your head and neck imaging, and then you have to put your arms up, scout scan the abdomen, and that is how you keep the right dose. If you do arms down and you scout scan top to bottom and then just image top to bottom, the dose will be higher wherever the arms are. Image quality, of course, will be okay for the body. So if you can only pick one, keep your arms down. But understand dose will be higher where the arms are because they have to obviously go through the arms.
Thank you so much.
Yes,
Yeah, that is
Dr. Nutri, can I have maybe
please.
the last question about
Yes.
the maybe related to technology and sustainability, because Dr. Brady also mentioned that if we can, we may need to have a new technology, CT technology every maybe 5 years, but on Asian Oceania region, certain countries may not be able to do that. So we may need a longer life cycle of the technology itself. So what will be the key features that you think that if you're going to consider the new CT, this is something that you must have and make the life cycle of the equipment longer? Thank you.
Yeah. So we have a scanner that's almost 15 years old. So even here in the US, we still use our scanners a long time. These are good machines. I would say the most important thing you can add, make sure on the life cycle, is the reconstruction algorithm. That would be iterative reconstruction. AI, if it is possible, but definitely iterative reconstruction. And then the second most important thing, if you're buying a scanner now for the future, is get one with a tube output that allows for high MA imaging. Most systems will allow you to go all the way up to 1300 MA for these new systems. And that allows people to image low KV. And that then we can talk about contrast differences, dose reduction, and all the same. So first things first, iterative reconstruction or reconstruction algorithms. And almost all scanners today can be upgraded to have iterative reconstruction. So even if you're not replacing your scanners, ask about reconstruction upgrades. And then two, if you're changing, double check to make sure you can get the best tube. And then going forward, those will last a very long time.
Thank you. That's very helpful. Okay, thank you.
Thank you so much, both of you, for giving an excellent lectures and compliment each other on the what can we do and what is the reality on the practice. So thank you so much. I really enjoy your lectures, both of your lectures a lot. Let me share a couple things for the audience. So let me share. Uh, mhm. So as I mentioned that. You can do the evaluation online on this QR code, so we know what we can do better. Can you see my screen now? Probably not. Hold on. Oops.
Can I share it, ma'am?
Yeah, hold on. I can share it. Yep. Okay. So this is a QR code for the evaluation online, and you can also watch the rerun of on this lecture on the Doctor platform. And I believe that after a month or two, we can have this thing on the YouTube channel, on the AOSR YouTube channel for you to watch the rerun. And save the date for the next webinar that we are going to talk about the dose optimization in the interventional radiology tool and technique. So we're going to have this webinar on the August 2nd. So we normally have this a webinar on the AsiaSafe on the radiation safety on the first week of Saturday. So the next one is going to be August 2. And if you I just want to give you guys a head of time that you can save the date on the first week of the Saturday. It's going to be August 2nd, September 6th, October 4th, and November 1st. Please save the date on those things, and we can talk more about and see more about on the radiation safety, how to optimization. So next time is going to be about the DR and IR. And Thank you so much, everyone, for joining us. Thank you, Dr. Wong. Thank you, Dr. Brady, for joining us, and thank you, all participants. So we are in for today. Thank you, Dr. Jamari, for joining us
Welcome.
with a very
I
fruitful
I
conversation.
enjoy a lot. Thanks a lot. Okay.
Okay, bye bye. We
Have
are
a good
done.
day.
Have a
Sawasdee
good
ka.
Thank you,
day.
ma'am.
Thank you.